Hi, my name is Pete Campbell. I'm an Associate Professor of Ophthalmology at the Casey Eye Institute, and I was asked to speak on telemedicine for retinopathy of prematurity. I have grant funding and I do some consulting work related to development of artificial intelligence for ROP, but I won't directly be discussing that in this lecture today. Telemedicine for ROP, this is what I'd like to cover. Why should we even consider it? What's required in terms of minimum necessary workflow and steps? What needs to be determined in each implementation? And why isn't it more popular? The two key take-home points I'd like to leave you with are: one, telemedicine has the potential to save physician time, reduce cost of care, improve consistency of care delivery, and improve outcomes. But implementation challenges currently limit uptake in the community. The AAP put out this policy statement a few years ago on screening examination for ROP that basically said ROP examinations, diagnostic examinations, can be done either with binocular indirect ophthalmoscopy or with ROP telescreening using remote digital fundus imaging safely and effectively. And that, when implemented properly, telemedicine systems using wide-angle retinal images and clinical data may be used for preliminary ROP screening or as an adjunct to binocular indirect ophthalmoscopy. What is required to set up this, a telemedicine program? Well, in this document, which was a joint statement, a technical report from AAP on telemedicine for evaluation of ROP, it goes through a very lengthy workflow, starting from when a baby is born, who identifies which babies meet criteria for screening, how do you determine the date, which camera system you're using, how are you going to set up image transfer, how are you going to generate reports, who is going to read the reports, how are you going to know that this happens, and how do you ensure babies don't get lost to follow-up. Sort of the basic nuts and bolts, but each program has to sort of document and assign responsibility for each part of that workflow, and that's really, really important. But also, each program needs to decide for itself how they were going to personalize these workflows, and that depends a little bit on the reasons why each program might want to implement telemedicine. Who's invested in the change? Is it that you don't have local ophthalmologists who are willing and able to screen? Is it that the ophthalmologist is motivated to save their own time so that they can do other things during that time? Who's going to take the images? Is it a nurse practitioner? Is it a bedside nurse? Is it a ophthalmic photographer? Who's going to buy the camera? That's a key limitation because these cameras are quite expensive, often more than $100,000. What's the data model for acquisition, transfer, reading, storage? Who's going to ensure patient privacy as personal health, protected health information is transferred between institutions? Who's going to read the images? How will they be notified? All of these things need to be sort of implemented on in each program. How will the person who's reading document and charge? When is a baby seen again? Are they seen every week? Or are they seen every other week? Who determines that? What happens if a baby needs treatment? Particularly if you're remote imaging, a baby might need treatment in a very remote location. Who is that baby going to be transferred to your hospital? Is there a local physician who wasn't involved in the reading who will be involved in the treatment? How do you ensure good follow-up? All these babies need follow-up long-term. And how do we avoid lapses? This is a huge medical legal issue in ophthalmology, and it is ROP follow-up. And you really need to ensure the workflow avoids these losses to follow-up. Why isn't it more popular? So reimbursement is low. The two CPT codes usually used are 92227 and 92228, and I'm not going to put the dollar amounts here because it'll change over time, but it's less than an in-person consult for ROP screening. Cameras are expensive. I mentioned this earlier. ROP cameras on the market range from $60,000 to $150,000, and given low reimbursement, it's a big barrier in terms of hospitals wanting to put that money out to have these cameras available. ROP screening contracts are a limiting factor. So many practicing ophthalmologists have lucrative contracts that put them in charge of ROP screening for a particular hospital, and telescreening could take that away. You then get into an issue where the local ophthalmologists are not involved in ROP screening, but maybe have to be involved in follow-up of the same babies, which leads to sort of challenges. And then finally, inertia. So if the system isn't broken, don't fix it. Although there are many ways I can argue that the system could improve population-level outcomes with implementation of telemedicine just through photo documentation, there's a lot of inertia to making those changes. And so, in summary, I'd leave you with the two key points. Telemedicine has the potential to save physician time, reduce cost of care, improve consistency of care delivery and outcomes, but that implementation challenges currently limit uptake in the community. Thank you so much for the opportunity.